It's a clear-cut diagnosis of cirrhosis by looking at all the nodular structures. Describe how you will be presenting it to an examiner. You might not be able to see all the notches and the lobes here because once we have established this is a specimen of liver. So what do I do next? Hey guys, welcome back to one more specimen of gross pathology spotters, and here it's a clear-cut diagnosis of cirrhosis by looking at all the nodular structures. Let's go and describe how you will be presenting it to an examiner, right? So this is actually not an entire liver. If you look, it's a slice of a liver. You can see this outer aspect. The only thing what we can appreciate in a slice of a liver to say it's liver is the shape, because you might not be able to see all the notches and the lobes here because since it's a slice, right? On the back, on the reverse side, if you can look, yes, again you can see just the raw surface here. You will not be able to appreciate any anatomical landmarks, especially when it's a slice of a liver. If an entire liver is given, how to say it's a liver? One, obviously is the shape of the liver. Then the lobes of the liver, you can see the left and the right lobe, and if there is any falciparum ligament, anything stuck there, you can say according to that, or the gallbladder fossa if you can appreciate on the below aspect of it. That also might help us saying that it is most likely the liver. If it's a slice of the liver, please go and stress more on the shape of the liver. Apart from that, you might not be able to see any anatomical description, or if you have a case history presented along with the specimen, that might help me to say, okay, it's most likely a liver sample, right? So once we have established this is a specimen of liver, so what do I do next? So if you look at the size of the liver, the first thing is, since a specimen of liver, for an adult liver, there's definitely a shrunken liver. The part shrunken should be very much emphasis, because you know that we are going to lead them to the diagnosis of cirrhosis. Cirrhosis has to be a shrunken liver. It has to be hard, but we cannot palpate a jar-mounted specimen. So shrunken liver should be there. On the outer surface, you can see the multiple tiny nodular structures. Cirrhosis by definition is nothing but fibrosis of liver with regenerating nodules, right? So the entire liver parenchyma is replaced by tiny nodules of varying sizes. Varying sizes makes it important for us to lead to the right diagnosis. And even on the cut surface of the liver, if you look, if you carefully appreciate, you can see multiple tiny nodules, especially in the periphery. It's not only on the periphery, it's actually in the center of the liver parenchyma also. It's more appreciated on the periphery, right? So once you establish there's a case of a cirrhosis of liver, then comes your VIVA questions. So what all can happen in a VIVA with respect to cirrhosis? The first, since a gross specimen, obviously the diagnosis and the classification comes based on gross. Though not very much useful in the current scenario, we divide cirrhosis into macronodular cirrhosis and micronodular cirrhosis. Quite a few of them will have a combination of macro and micronodular cirrhosis. Macro, the definition is anything more than 3 millimeter, it's millimeter not centimeter, more than 3 millimeter nodules, we say it's macronodular, and if it's less than 3 millimeter nodules, we say it's micronodular. Do I need to read the table which causes macro and micro? I would honestly say no. But do remember that one of the commonest causes, which is alcoholic cirrhosis, is a combination of both macro and micronodular cirrhosis, and also has a name called as Laennec cirrhosis. And one of the other things, like the common cause of cirrhosis being Hepatitis B and Hepatitis C, the chronic hepatitis. Post-necrotic or post-hepatitis cirrhosis are generally a macronodular cirrhosis, right? These are two things which you have to remember. Is cirrhosis reversible? That could be a question. Definitely cirrhosis is an irreversible condition with respect to an undergraduate, right? So the cause of cirrhosis. The leading cause being alcohol. The next causes can be your Hepatitis B and Hepatitis C. Other hepatitis virus rarely lead to cirrhosis. Most of them cause acute liver failure, right? Apart from that, you have lots of metabolic disorders like an hemochromatosis or an alpha-1 antitrypsin deficiencies. They also can lead up to cirrhosis. But the chunk, as we stated, it's going to be your cirrhosis, is going to be alcohol and your viral hepatitis. Fine. So how will a patient with cirrhosis present? Cirrhosis most of the time will present with portal hypertension. The classical features are ascites, which is nothing but due to reduced albumin production by the liver, and also the increased pressure due to portal hypertension. And you'll have the variceal bleedings and all the portosystemic shunts, where you can see them in the esophagus, you can see them in the bad area of the liver. Remember the umbilicus, the caput medusae, the hemorrhoid piles, you can see classical portosystemic anastomosis. Third, you might definitely see patients in terminal stage of hepatic encephalopathy, where the ammonia, which is in the form of the gut bacteria, has not been able to process by the liver. The toxin hits the brain and causes encephalopathy. So these are the classical procedures of cirrhosis with portal hypertension, right? These are things which can come in the exam. And do I need to document cirrhosis in microscopy? There's only one requirement to document cirrhosis: when the patient is a candidate for a liver transplant. Apart from that, we need not require to document cirrhosis on a microscopy. An ultrasonogram is more than enough. And the needle which is useful for liver biopsies, Vim-Silverman needle, right? That's all regarding this sample, and see you soon in the next video. Till then, bye-bye.